Welcome and thank you for standing by. We'd like to inform all participants your lines are in a listen-only mode. During today's question and answer session, you may press *1 on your touch-tone phone. Also, today's conference is being recorded. If you have any objections, you may disconnect at this time. And now I'll turn today's meeting over to Dr. Ed Kraft. Thank you. You may begin.
Thank you, Candy. I am Ed Kraft, CSAT's methamphetamine lead and the Government Project Officer for SAMHSA's National Meth Summit. Welcome to SAMHSA's webinar series, Methamphetamine, a webinar series dedicated to promote public health, partnerships, and safety for critically affected populations. Today's topic, Justice-Involved Persons in Meth, addressing a full continuum of services, will focus on the range of services available to those involved in the criminal justice system. Presenters will discuss resources which include recovery and community services, monitoring systems for products containing ephedrine, and reentry support and services for ex-offenders being released back into the community. Law enforcement identifies methamphetamine as one of the most difficult drug issues it faces. Looking back, we see that the criminal justice system was years ahead of the public health system in its recognition of the methamphetamine crisis. Criminal justice's involvement came through its discovery of methamphetamine labs and its response to the effect these labs had on children, the environment, and other related issues. The criminal justice system was aware of the consequences of methamphetamine addiction, but was so busy dealing with prison overcrowding too busy to address the issue, and parole agents had no choice but to incarcerate offenders for their methamphetamine abuse. While many individuals who are addicted to methamphetamine and come out of corrections need the most help and may be the hardest to treat, we know there are now a number of evidence-based practices in place today that can help. Drug courts, family drug courts, access to recovery, screening, brief intervention and referral to treatment, and targeted capacity expansion methamphetamine are some of SAMHSA's programs that are making a difference, and in some cases showing a robust reduction in methamphetamine use. However, at SAMHSA, we also know recovery is a process of change. Addiction is a chronic disease, not an acute disease, and thus a disease treated only when symptoms are severe. Most people experience multiple treatment episodes before success. At SAMHSA, we believe the Recovery-Oriented Systems of Care, or ROSC approach, addresses this issue and provides a shift to person-centered recovery. ROSC focuses on a self-managed, person-centered, self-directed approach to care that builds up the strength and resiliency of individuals, families, and communities with a comprehensive menu of services and supports. A system that focuses on a continuous treatment response and self-care will help people move into a recovery zone, as will early intervention and support for sustained recovery efforts. Adopting the person-centered, self-directed approach to care does not mean people will not have relapses, but that relapses are managed as temporary episodes. Now, before we continue the webinar, I'd like to go over a few details that might be helpful. We will be holding all questions till the question and answer session at the end of the webinar, at which time the operator will review how to use your touch-tone phone to participate. If you need technical assistance at any time during the call, please press 0 to speak to the operator. Starting us off today is our first speaker, Lori Moriarty. Commander Lori Moriarty began her career in law enforcement in Colorado in 1987. From 2000 to 2006, she commanded a multi-jurisdictional undercover drug unit just north of Denver. Commander Moriarty was instrumental in implementing protocols for the safe investigation of methamphetamine labs and undercover drug operations. Commander Moriarty is currently the Senior Vice President of Education and Outreach for the National Alliance for Drug Endangered Children. She has appeared on ABC News 2020, Fox National News, MSNBC, CNN, NPR, and PBS in an effort to educate citizens of the effects on children living in dangerous drug environments. The Office of National Drug Control Policy recognized her as the 2001 Drug Commander of the Year. In April 2005, Commander Moriarty testified before the House Judiciary Committee in Washington, D.C. on H.R. 1528, Defending America's Most Vulnerable, Safe Access to Drug Treatment and Child Protection Act of 2005. Commander Moriarty.
Excellent. Thank you, Dr. Kraft. I appreciate the opportunity to present at this webinar today. And I think you've hit some important issues right at the beginning as far as how we have to deal with the methamphetamine epidemic, and not only how it relates to the user and those who are trying to get into recovery, but the next generation as far as the children. And the holistic approach that we're going to have to take with multiple disciplines working together, and until we can all understand the dynamic of what the drug has done, it's hard to have a nice, good, collaborative response. So hopefully that's some of the stuff that I'll be able to cover today as I go through my presentation. First, I'd just like to show a little bit about the National Alliance for Drug Endangered Children, and there we go. The National Alliance for Drug Endangered Children provides training, technical assistance. One of the core strengths of the Alliance is the state DEC alliances throughout the nation. There are 22 state DEC alliances associated right now with the National Alliance, and hopefully one of the goals is to have all 50 states working together so that we can help break the cycle of abuse for children living with substance abusing parents. The goals is to raise awareness, and as Dr. Kraft had mentioned, hopefully provide support and information and resources to local communities and state DEC alliances who are dealing with not only methamphetamine but other drugs in their communities, and kind of showing, as Dr. Kraft mentioned, that sometimes recidivism happens, and in the mix of all of this, what are we doing for the families as a whole to help break this cycle? So prevention in situations, encourage early intervention, and network experts and professionals. Today what I'm going to go through is some of the stories that I think will just help us recognize how we've missed children in this population, and if we're going to be dealing with the children of substance abusing parents, obviously the goal isn't to remove every child from their parents. The goal is to do what's in the best interest of the children and the family, and treatment and recovery is a huge part of that, and identifying the children at the earliest point possible is what will help us to break the cycle for that generation. So the goal for the National Alliance for Drug Endangered Children is to start finding all of these children and providing intervention in the family to help break the cycle. I do want to cover real quick the history of drug endangered children, because I think Ed hit on it as far as how long law enforcement has been dealing with the methamphetamine epidemic and where the drug endangered children effort started, because for law enforcement it goes back into the 1990s. 1993 is when Sue Weber Brown actually first recognized children living with the substance abusing parents and the impact that it was having on that generation, and that, you know, you would arrest a parent, and then as a law enforcement officer, within 5 or 6 years, you'd be, you know, arresting the children, or within 10 years. And it just kept being generational and generational, and we recognized that, she recognized that a lot of the work that law enforcement was doing was not in collaboration with social services, which was one of the first parts of intervention. So Sue actually really started helping law enforcement work collaboratively with social services, which then has led into all of the different disciplines that respond to these issues: probation, parole, the drug courts, school districts, all of those that actually have a part in the holistic approach to these families. The other issue that came about in 1995 was this case with Kathy Lynn James, and it really sparked the law enforcement's response to recognizing children growing up with parents who were manufacturing methamphetamine and the dangers. And I would have to say that methamphetamine was one of the worst drugs we've ever seen in the history of substance abuse, because it not only had the use and the manufacturing and distribution, but it had for the first time, communities started seeing the impact, and they quit seeing the substance abuse as a victimless crime. A lot of people were not paying attention to those who needed treatment and needed to try to help them get into recovery, because people would just ostracize a user and put them off like, well, that's their issue, that's their problem, and they wouldn't look at it in how it was affecting the user and the community. So this one really kind of changed things when the lab blew up in Riverside, California, and these 3 children perished in the lab, and one of them was actually standing at the back window where Kathy Lynn James had escaped. So she escaped, leaving behind 3 of her children who burned to death in that fire. And that opened up everyone's eyes to the impact of children living in these dangerous drug environments. At that point, we also recognized that it wasn't just labs, that it was all the illicit drug abuse and any kind of substance use that incapacitated the caregivers. So Kathy Lynn James in 1997 was actually sentenced to 45 years in prison for the murder of the 3 children. Drugs in children for the Drug Endangered Children effort, really this is the ultimate goal, and the thing that we missed was, as you know, when I did 6 years as the commander of the Undercover Drug Task Force, my goal and attention was on the substance abuse. And it was arresting the offenders for use, manufacturing, distribution, cultivation, whatever it was associated with the illicit drugs. And to be honest with you, I'm ashamed to admit that the entire time I was doing that, I missed the impact on children living in those environments, and that was the next generation, and that we had an opportunity to intervene in their lives at an earlier point, yet we had missed identifying them to move forward with that. So the other part that I did was an investigator of child abuse, and I have to tell you that in my 2 years of investigating child abuse, I missed the significant factor of substance abuse being the primary reason for the child abuse cases. So even in my own world of law enforcement, I wasn't connecting the dots, and in child abuse cases missed substance abuse, and in substance abuse cases missed the child abuse. And that was really what brought my passion for the Drug Endangered Children effort, and to think about how we were going to change this cycle in the future if we didn't recognize these kids. So the definition under the National Alliance for Drug Endangered Children are children who are at risk of suffering physical or emotional harm as a result of illegal drug use, manufacturing, cultivation, or distribution. And these risks can include, obviously, physical abuse that is associated with this, emotional abuse, sexual abuse, neglect, including the failure to nurture, supervise, provide meals, sanitary and safe living conditions, and schooling and medical care. Those were a lot of the impact and risks that happen with these children. A couple of stats here that I want to show, and just kind of my point in these is to show how we have missed these kids, but 9.2 million children in the United States live with a substance abusing parent or substance using parent. Now this stat is from CASA, and this next stat is 2.1 million children in the United States that comes out of SAMHSA. The difference in the two stats that I just want to make a point here is what you consider a caregiver actually using in the home or a parent and the illicit drugs. So in the CASA report, that covers all use of illicit drugs and not just dependency or abuse. And the CASA report also includes illicit drug use by any adult in the household and not just the parent. So that could be the discrepancy in the numbers. But I want to show this number as well, because this really hit home with me as a drug commander, that there are more than 35 million individuals who use illicit drugs or abused prescription drugs in 2007 alone. So if we think of our last two numbers, as far as 2.1 million or 9.2, if there are 35 million individuals, how many people are we missing an opportunity to intervene in their lives, especially the children of those users? This is a quick study that we did, an example of a study we did when I was the commander of the North Metro Drug Task Force out of Sergeant Jerry Peters, who actually took some stats. This year, we had over 800 arrests. And you can see here that we took 88 of them, and we started collaborating with social services. Of those 88 arrests, how many children were associated with those families? And in the past, we would have said 0, because unless the child died in a lab or was in a meth lab, you know, exposed to the chemicals, or if the children were at school and we didn't go find them, or somebody came to a drug deal and we didn't go, maybe go back and check the house to see if they had left their kids at home to come to do the drug deal. But when we actually took the time to identify the next generation of those 88 users, we found 137 children. And that was 10% of the arrestees that we had that year. Of those 137, 50% already had Department of Social Services history, and only 12 were open cases, meaning 38% of the 50% were closed cases. So we asked social services, why were these closed cases? And they said because they couldn't answer a risk assessment of substance abuse in the house. Well, that struck us pretty hard because in law enforcement, we can answer that question all the time, yet we weren't collaborating with other disciplines to help to take care of that and work together to identify the children. So children of parents with substance use disorders have a higher likelihood of developing substance use problems themselves. This is why it's important that we all start collaborating together. Child abuse and neglect increases a person's risk of later substance use, and individuals with substance use disorders are more likely to abuse and or neglect their children. In addition, children whose parents abuse alcohol or drugs are 3 times more likely to be verbally, physically, or sexually abused, and 4 times more likely than other children to be neglected. Strong significant evidence also suggests that addiction tends to run in the family. So this is where we're talking about the intergenerational, the next generation coming up that in law enforcement we said we will be arresting them. So Drug Endangered Children effort is about collaboration. We hope we're a resource for state alliances and local communities to help develop the collaboration that occurs to eliminate the substance abuse problem. And when I say eliminate the problem, Dr. Kraft mentioned it, it's about identifying a holistic approach that if in fact we can keep the families intact and get treatment for the entire family, this isn't, a lot of people look at drug endangered children like it's the law enforcement, coming in and arresting and throwing people in jail. It's not. It's about the fact that we identified we've missed the next generation, and in order to effectively respond to them, we have to respond to the whole family, but most importantly, what's in the best interest of the child for their future to break that cycle. So some of the examples, I'm going to go through these really quickly, but the risk of physical abuse just by children living with substance abusing parents is erratic discipline, irrational rage, increased irritability, drug-exposed infants. Some other risks of neglect include lack of supervision. This is a child that's by the swimming pool. In law enforcement, I can't tell you how many times we actually went on to calls where the children were just running around the entire neighborhood with no supervision, and when you actually looked into it, it was an incapacitated caregiver or a caregiver who was high on drugs and didn't even know where their children were. And as I mentioned, I'm covering all illicit drugs, but methamphetamine was the one that got us here. If it hadn't have been for methamphetamine and the impact that it had on all people being victims of the methamphetamine epidemic, I'm not real sure we would have crossed over into the need of a holistic approach and a collaborative approach with all disciplines trying to figure this out together, which is why I'm very happy to be presenting on, with SAMHSA on this. As a cop in law enforcement, I have to be honest with you, we never recognized that treatment worked, that there was anything called recovery, because when you think about the people that we're dealing with are people who are not in recovery because we're continually arresting them or they're in relapse. And so until I started working with treatment providers was when my eyes were open to recovery and then believing in access to recovery for children and families. So the lack of necessities, the dangerous home environments that these children were living in. Again, I've mentioned incapacitated caregivers because of their substance use, exposure to illegal activity that occurs with the drug crime and what happens when you're dealing methamphetamine, manufacturing, that you'll do anything to get the next hit or your next use. Obviously, drug dealing. I can't tell you how many times children were brought to the drug deal when we were doing undercover investigations, drug transporting, ongoing use. And all of this is in the presence of children. And I know a lot of times the caregivers or the parents feel like, well, I use drugs, but my children don't know. And I'm to tell you, the children do know, and I've got a couple examples that are coming up here. But these children are exposed to violence, drug dealing, kidnapping, home invasions, and other risks that occur, overlay deaths. I've got some stats on, cases that were reported as SIDS, but when you looked back into the information, in one case, in one particular incidences here in Colorado, over 50% of the overlay deaths had substance abuse involved. Exposure and ingestion to the drugs that are left out, sexual abuse, emotional abuse, loss, foster care placement, with how many kids end up in the foster care placement and don't get out because of their parents' substance use. And so together we're going to have to figure out how we can all tackle this issue together, and what kind of resources we can provide, and the state DEC alliances, what they can do, and the training and education that we can get out there. So drug and endangered children are a high-risk population. If we're going to talk about preventing substance abuse, we should really be focusing on this generation and stop it at the earliest point possible. And these are the most high-risk youth that are out there. Examples of some of the abuse that occurred, and again, I'm going to go through these fast just so that I can cover it with the time that we have, but I did want to throw a few examples. This happened to be cocaine use in Houston, Texas, where the mom actually emasculated her 5-week-old son while she was high on cocaine. She tried to blame it on the dog in this situation, but it was very obvious that she had removed the 5-year-old's genitals, which were never found in this case because she was high on drugs. Another one here, this one happens to be PCP, where this gentleman bit out his 4-year-old son's eye and then started attacking his own leg with an axe while he was high on PCP. The unfortunate part about this one is that there was also a history of PCP possession and the child was involved in the situations earlier. So it was a missed opportunity to intervene in these lives in 2006. This one here happens to be marijuana, and this lady actually, in the presence of law enforcement, slammed her 16-month-old baby down on the table in front of police from about 2 feet high. And at the time that the police were investigating this, they were responding to a loud party and a fight between 4 people. And even with officers present, she didn't pay attention to the protection of her child, that she slammed him on the table in front of them. This example here is another example of marijuana where the mother, this happened to be a mother and father, were separated, and the mom had called because she feared that the children were drinking alcohol with their father. And when the police got there, they found this 2-year-old who was sleeping, and when they rolled him over, they found the handprint on his face, and the father admitted that when he got angry, he was angry at the child for jumping on his guitar. And he actually said that that injury occurred when the child fell at a park. He never admitted to slapping it, but when he put his hand up next to the face, it was a perfect match of the father's hand up against the child's face. This last example that I have here is one more, marijuana using dad in West Virginia. And this case comes from Brandon Lewis, who was in the coroner's office in West Virginia. But the father had actually given the children a bath and said that he was going to go fix dinner, but ended up sitting in the living room smoking marijuana with several of his friends. And they forgot that they'd even put the children in the bathtub. And the next thing that brings our attention to this is when water is actually running down the hall into the living room where they are, and they find the 8-month-old dead in the water, and the 2-year-old still taking a bath with the child. And so literally the tub had to overflow before they even remembered that they had placed the children in there to take a bath. So those are just some of the examples of the impact on children. And our point, and I again appreciate the time that we've been given to do this webinar, is when do we take action to protect the children? And I know that it's going to have to be a holistic approach with the whole family. When do we consider illicit drug activity alone justification to intervene? And do we wait until additional maltreatment circumstances arise, and what if we wait too long? So when can we start intervening in these families' lives? The National Alliance for Drug Endangered Children recognizes the element of cooperation and teamwork that must occur between service providers. It's truly a critical piece of our effort. And as Dr. Kraft had mentioned earlier, this is going to take all of us. Treatment is now talking about what is it going to mean to work with law enforcement and courts and probation and, the public health. So you'll see here prevention, medical services, child welfare, the public health, federal agencies, nonprofit organizations. It truly is going to take all of us as resources to make a difference. I will have to say, in my experience with this, working together feels like it brings risk and accountability because we all open up the skeletons in our closet, which is one of the biggest things that keeps us from collaborating. But the children give us a reason to work together and put those issues aside. We all have to have a common outcome of protecting and serving the children and the families. And so we can't do it alone. Each discipline is going to have a role and responsibility, and that's what the National Alliance for Drug Endangered Children is all about and focuses on. I throw this picture up just as an example that when I talk about all different disciplines, law enforcement, social services, probation, treatment providers, the list that I just had on the slide before, we all bring a different perspective to the table. And until we start talking and sharing information, we won't see the same picture. And we might not seem to see the same picture for a long time, but we have to recognize that we have to look past our differences. When I do this training, it's amazing to where 50% of the audience sees the old lady and 50% of the audience sees the young lady. That's how it is when we first started going to some of our scenes where law enforcement saw one thing at the house where the illicit drug use was taking place and social services saw something else. But until we started sharing information and talking and working together, we were ineffective individually, but we became extremely effective collaboratively and together. This is one example of one of the cases we had when we started working with social services. We made it a point to call them before we even went to the home. And this one, the 4-year-old Kayla actually met the SWAT team at the door when the SWAT team hit it. There was 12 officers going in on this one, and she just held the door open for all 12 of them to go through. So we had already called social services, so they were on scene with us. They were able to do the interview with Kayla, and they were planning in their meeting that they were going to let Kayla go with Grandma. Well, interestingly enough, when you had social services and law enforcement on this scene together, when law enforcement found out they were going to let Grandma take the baby, then they started checking to make sure Grandma was a safe place. And ironically, where we found all of the drugs were actually in Grandma's room. Grandmother happened to be the first generation that started the use, that started her daughter, and then the daughter was the one we were going in to arrest. But this investigation found methamphetamine in the headboard. Kayla had mentioned that she slept with her grandmother. And to this day, Mom is clean and in recovery and has custody of Kayla back from everything that I've heard through the recovery groups here in Colorado, and Grandma is still out on a warrant for her arrest for failure to appear. So what we thought was giving the child to Grandma was not going to be the best case, but we had to do it together. Kayla said she ate ice cream out of the refrigerator where we found several parts of the methamphetamine manufacturing lab in the refrigerator. So a child has to go around this to even fend for themselves. In this case, real quickly, is Romeo. We went on this case again with social services. They told us there were going to be 2 children in the home. Romeo came out and was looking up and down the street as law enforcement was surrounding the house. It was early in the morning. And when he was looking up and down, law enforcement actually thought that he was counter surveillance, looking to the right, looking to the left. And it wasn't until he came out and I asked him what he was doing when he said he was actually waiting for a bus because today was his Halloween costume party at school and he really wanted to go. But he couldn't wake his mom up and he didn't know where the bus stop was. So here's a 4-year-old fending for himself because his mother is passed out because of methamphetamine. And so there has to be intervention in this kid's life. And if you see here, Romeo told me he knew why we were there. This is a 4-year-old that was actually able to draw a meth lab. So here's a picture of a lab. Here's his drawing. And he couldn't count to 7. That is him. He wrote his name. And then he told us if you do that thing that looks like a 7, if you're at the top of my street, you go all the way to the end and turn right to the bottom, then you will find that's where my mom's boyfriend makes his oil or his methamphetamine. And so because of the collaboration with social services, we were able to find the child that was also in this home with the brother, which we would have not found had we not collaborated. This is just a statistic from 2007 fatalities, 1,760 child maltreatment fatalities in 2007. And these stats are 2007 because it takes that long to actually get the stats completed, so this is the most recent stats we have. Neglect caused more child fatalities than physical abuse. The Drug Endangered Children effort will often create a shared passion and desire to address this issue and work together. Excuse me. This picture here is really truly just to represent that it's a long road that we have ahead of us, but it's going to take all of us to do this together. The Drug Endangered Children effort and our collaborative mindset, believes that to break the cycle of abuse and neglect, we need to empower practitioners to work to transform the lives of children and families living in drug environments. The mission of DEC is... these slides got a little bit off when we converted them, but the National DEC approach is to work with state DEC alliances. We have a resource center to gather the most recent information and requests that come in from the local communities and state DEC alliances. We have a national conference annually. This year will be our 7th annual conference in Texas, and training and technical assistance is our approach. And so we hope that all of the resources we have could benefit anybody that's out there watching this webinar today. We do believe in a collaborative mindset that it's going to take all of us. This is just an example of what we believe the Drug Endangered Children effort does. If you look at each of us individually in silos doing our own piece independently, we're not sharing information, but when you give us a reason to work together like the Drug Endangered Children, we all become one and we share information, and I think it'll be a more holistic approach. Collaborative benefits allows every community to engage in the Drug Endangered Children practice. It does not rely on grant funding. Truly, when I became the commander and started working with the Drug Endangered Children efforts, this was just something that we changed practice by how we did it and our mindset, and it wasn't something that cost us a lot of money. Collaboration doesn't cost money. It's the other parts of the resources and services that we want to provide that do, but the collaboration doesn't. Sustainability does not rely on individual champions, and it allows for a comprehensive intervention to address the long-term emotional impacts on children. As I mentioned earlier, we have a National Alliance for Drug Endangered Children conference that's coming up, so I'd like to make sure we mention that. We'll have multiple disciplines from all different perspectives presenting at the conference so we can try to hit the collaborative approach. And at the bottom there, it's kind of hidden in the text at the bottom, but the National DEC website, www.nationaldec.org. And so I'll save anything for questions at the end, but again, I want to thank Dr. Kraft and Sampson, the Meth Summit, for giving us this opportunity to share, and hopefully we can provide resources and services to those who are working on collaborative efforts as well.
Thank you, Commander Moriarty, for that excellent presentation. Joining us now is our next speaker, Edward Gomes. Eddie is currently the Hawaii Pacific Regional Coordinator for the National Meth Center. He has over 34 years' experience in the law enforcement, health, and safety field, and is well-versed in the areas of narcotics, environmental, health, and safety issues in conjunction with state and federal agencies. Previously employed with the Hawaii State Narcotics Enforcement Division and the Hawaii Attorney General's Office, Ed has formed a wide network of community and government alliances to effect meth reduction in Hawaii and the wider Pacific region. Through his governmental, cultural, and community relationships, Ed's focus has been to build safe communities and healthy families. His focus has a strong emphasis on cultural approaches to prevention and recovery programs. Mr. Gomes?
Thank you, Ed. Thank you very much. And Laurie, very compelling presentation. I'd like to start out before we get into the slides to talk a little bit about the National Center and how they came to be a partner in Hawaii's methamphetamine effort. I had spoken to our two directors, Priscilla Lisicic and Terry Schmidt-Wellen, prior to them coming to Hawaii in 2007, and then again, starting again in 2008, and asked them to do a legislative information briefing on the first day of legislature, January 16th, 2008. In that meeting, we had invited legislators, law enforcement, attorney general office members, and state law enforcement people. And it was broken out into two sessions. The sessions ran morning and afternoon with a working lunch session. Well, everybody showed up in the morning. Broke for lunch. Nobody showed up for the afternoon session. I'd just like to say this ties in with Lori greatly. About 1 o'clock, we started getting telephone calls that everybody was stuck on the freeway. And in subsequent telephone calls, we had found out that a little boy by the name of Cyrus Belt, who was 2 years old, was thrown off of the walkway overpass and onto the freeway and hit by a car. Now, in saying this, the gentleman who threw him off was not a parent or relative of the child. He was a neighbor. But in this whole scenario, he was high on methamphetamine. The mother, who wasn't present, was high on methamphetamine. All the family members, including grandparents, were high on methamphetamine that day. The grandfather had fallen asleep because he'd been tweaking for a number of days. The father of the child was actually in prison. The mother's boyfriend was high on methamphetamine. This child had gotten out twice before that day and had been picked up by a Honolulu police officer and returned to the family. So what I'm trying to say is we see a lot of collateral damage with methamphetamine issues here in Hawaii, and it's a tie into Lori's tech presentation about where do we connect to try and effect change. So in saying that, when this occurred on the first day of Ledge, Terry and Priscilla decided to make Hawaii the first regional center and move on out across the nation to make 5 other centers in strategic locations. Now, Hawaii's methamphetamine problem was never a production issue. We never had the small mom-and-pop labs that you folks have seen. It's always been driven by supply from the mainland and cartels across the U.S. and in Mexico, and also in Southeast Asia. Actually, the first supplies we saw were coming from Southeast Asia as far back as the mid-'70s, and very high-quality, pure methamphetamine, upwards of 90 to 100% in that range, purity. So in looking at the start of this problem, we were well ahead of the curve in meth supply. In saying this, the outcome of that has been our population basis being affected. Go to the slides now. So what we've done is we've tried to figure out different strategies on how to affect our population to get our communities wrapped around this effort to try and stem methamphetamine use and try to build wellness into our communities. And one of the main focuses has been our prison population, try to affect them. Also trying to look at our recovery and treatment programs and the efficacy of these programs and how well we can return our populations, our prison populations, to the general community. So what we've done is we've taken a number of different initiatives, especially now with the budget being, or the fiscal situation across the country being so dire as far as social services go, how we try and bring these populations back into the community with a much smaller treatment and recovery budget. One of the focuses or initiatives we've done here in Hawaii is to address our legislators again to try and move dollars away from incarceration. Look at how we classify our prison population and try and get them back into community custody hold. And hang on just a second. Try to get them back into a lower custody holding than what they currently are, medium and high security. A lot of these offenders are first-time drug offenders. Mixing them with the general population has not been a very good strategy. They come out, they've been warehoused, and we don't see any kind of positive effect on their incarceration time. So in looking at this first slide, forward-looking strategies, some of the things we've done here is when we say investing in alternatives to keep non-violent offenders out of prison and off the public assistance, what we try to do is affect our legislature to pass legislation to move the monies more to treatment dollars, to Hope Probation, to Hope Parole, pilot probation programs. Okay, Hawaii's statistical data, as you can see, our taxpayers pay $50,000 for a prisoner for 1 year. We've looked at that data, and through our Senate head of public safety, Senator Willis Sparrow, he's looked at that money, and he's now trying to figure out how much of that we can move to treatment dollars. We have over 6,000 people incarcerated in the system in Hawaii. 2,000 of those are incarcerated in CCA, or Correctional Corps of America. We're one of the largest customers of private pay prisons in Hawaii, so, or not in Hawaii, but in the nation. So what we try to do is we're going to move some of that treatment money out to the programs, lessen the community, lessen the holds to community status for many of our incarcerated people, move them into the Hope Parole pilot program, and bring them back into the communities. One of the things that works most effectively for us is keeping our inmates engaged with family, keeping them employed, working with life skills programs to try and bring them around and be community, healthy community members. What we don't see out of the prison system at this time is anything that effectively helps them in great numbers. What we look at is, from the National Center standpoint, is we looked at the most affected portion of the prison population. And that happens to be our indigenous people's population, our Hawaiian population here. The Hawaiian population here represents 20% of our overall population, but it represents 40% of our prison population, and that number is a very conservative number. That number has to do with, the way the data was collected was a self-reporting form. We believe that number is higher. It's probably around the 60% incarceration level. So what we try to do is affect the programs that deal with Native Hawaiian populations. And why I say this is this same model can be rolled over and duplicated on a national level, looking at other populations and other gender-specific populations. I've been involved in a number of these programs prior to coming to the National Meth Center, and we see a high level of success by dealing with these populations on a cultural or with a cultural approach. as you can see here from myth number 1, there are no prisons in paradise. Our prison population was only 926 in 1980. In 2008, it was 6,004. According to Judge who runs the Hope Probation program, 95% of our cases, not just our prison population, but our parole, probation, prison, federal incarceration cases, 95% of those are drug-related, and the majority of those, high 90%, deals with methamphetamine. Methamphetamine has been the drug of choice in Hawaii from the early 70s up until our weed and seed and our green harvest program, which is our marijuana eradication program, became a high priority in the 80s. That more or less fueled a sharp rise in methamphetamine use again within the community. So 95% of the people that we see, not only in prisons, with the number being 6,000, but in our overall population, I have a slide here with the total numbers, and that number is someplace around 25,000 people that the majority of them are methamphetamine treatment or methamphetamine trafficking and distribution connections. I forwarded on to how we affect our cultural base here in Hawaii, our Hawaiian base. So one of the things we do are look at alternative connection models that we have for Hawaiian community, and this is not only specific to our indigenous populations. Many of our other cultural groups attach and identify with these models. One of them is a prison program that we have that's called Pohaku Okane. It stands for a life measure program, or the basis of it is a Hawaiian connection on Hawaiian values, on traditional processes that we use. This photo I have here has to do with a process we call makahiki, which is a yearly traditional time for peace and healing in the community. At this point, we have about 600 of our 2,000 inmates in Arizona utilizing the processes in these programs. So we try to use a cultural intervention for substance abuse and mental health. That is where many of our funding dollars have been moved over from the legislature. Our legislature looks at these processes that are and are placing I'm sorry, Ed, I'm having a little phone trouble right here. They're looking at it as where we guide our programs from. And our programs here, many of our programs, especially our legislative initiative, our legislatures look at the Ed, I'm sorry, I'm having a problem with my website. I'm not able to, my slides are just going all over the place. Can you hear me at this point?
Yes. Yes.
What we will do is we'll advance your slides. Just let us know when you'd like it to be advanced.
Okay. So, like I said, our approach has been spearheaded. The National Center has connected with our elders in the community to try and get the message out from a different point of view. What we use is our kupuna, our elder model, to get our message out to the community as one of our special initiatives. been highly effective. Community here looks towards our elders for a message or for a responsibility to move forward. So within the Hawaiian community, that message is very, very, very highly regarded. Can we go to the next slide? Okay, so when we look at incarceration, when we look at alternative treatments, so when we look at cultural communities, I know how we move these models forward are on evidence-based best practices. What's been unique here is trying to equate some of our programs here with national models. We've started to do that. There's a big research effort to try and move forward and identify these Hawaiian principles and practices and equate them to best practices Western medicine. There's a group here that we support. They're called Iololahui. They have done a 3-site study and are now in the process of validating the processes that we use and moving them out into a national stage to try and duplicate within other communities nationwide. One other thing I'd like to cover is the HOPE probation, which stands for Hawaii Opportunity Probation for Enforcement. Judge Stephen Alm, who we work with, has been very instrumental in starting out a probation program that is incentive-based, and it's a high-intensity supervision program. But what has been successful about this is the sanctioning methods that Judge Alm is using. What we're finding is that bringing in people into HOPE probation who are either pre-sentenced or are sentenced to the probation program. When probation usually fails and a person is incarcerated, it's over a long period of time. What Judge Alm has found is that short, immediate sanctions from 1 to 3 days, up to a week, up to 2 to 3 months has been highly effective. That's the teachable moment for HOPE probation. Some of our cultural programs are also initiated through HOPE probation, so that holistic approach of trying to affect change in our inmate population and in our probation and parole section has been highly effective. Judge Alm is currently presenting this on a national stage through the National Drug Court. Some of the stats that he's shown through HOPE probation is that positive drug tests have been reduced by 86%. How the drug test portion of HOPE probation works is there is a color and a number assigned to each person that's within the program. You call in every day, you listen for your color, and you listen for your number. If it comes up, you have 4 hours to get down to the probation office for a UA. By doing this and monitoring them so closely and knowing that the immediate sanctions is going to, the disruption of their current cycle, you're either going to abide by the program or you're going to end up with a sanction period that it's basically turned around. As you can see, a high number within that base. His benchmarks for success are HOPE probation involves swift and certain but relatively mild sanctions, jail time for each detected violation of probation. When properly done, HOPE results in greatly reduced drug use, missed probation appointments, probation revocations, and arrests for new crimes. What is unique about HOPE probation is in looking at the dollar cost for the program, which is about $567 per per person, it is much more effective than the $50,000 we're now utilizing per person for a yearly incarceration. So what the legislature, through our initiatives, has done is to open up what's called the Hope Parole pilot program, where we're going to take those first-time drug offenders or the low-risk offenders which are now incarcerated within the system, bring them back to community custody, and put them into a pilot program very similar to the Hope probation program. Another tie-in to the holistic piece here has been our access to recovery money through SAMHSA. When you look at the data on how we bring back inmates into the community custody, if you'll look down to the second bullet point here, that 42% of the ATR patients are on probation or parole. So this program has been highly effective in bolstering Hope probation and Hope parole pilot. Okay, alternative treatment strategies include forward-looking thinking initiatives and programs that are community and are culturally grounded. Success for justice's affected clients means healthy families and communities and generational sustainability. That's my final slide. I'm looking at my time here. I know it was a little disconnected. I'm having terrible problems on my computer here, so I must say, excuse me again. Ed, thank you very much for this time, for letting me to provide a little bit of what we're doing out here in Hawaii. Again, I'd like to say that the model that we use here can be duplicated into many other populations in the nation. I like to think that our decision processes are not linear, but our decision processes are circular. So where we end up is just a new beginning for our next step. Again, I'd like to turn this over to you, Ed, and thank you very much.
Thank you, Mr. Gomes. We appreciate that excellent presentation. I'm just going to turn it over for a moment to Serafina Mesa, who's going to explain to you about downloading the PowerPoint presentation.
For those of you who would like a copy of the presentation in PDF format, if you look at the top of your screen on the right-hand side, you'll see an icon with 3 pages. If you click there, you'll be able to download copies of the 2 presentations that you saw today to your computer. These presentations will also be available on methpedia.org for download, both in a video format as well as these PDFs that you see here at the top of the screen.
Thank you, Serafina. We would now like to open the floor for questions. Candy, will you please explain the process to pose a question and open the line?
Thank you. At this time for questions, press *1. Please unmute your line and record your name to be introduced. Again, for questions, press *1. If you'd like to withdraw the request, you may press *2. Thank you. One moment for your first question. Again, for questions, press *1. All right, thank you. It looks like we do have a question coming in queue. One moment, please. All right, thank you. Carol Justice, your line is open.
Thank you. First of all, a comment. This was one of the best presentations I've ever seen on this topic. Thank you so very, very much. My question is it possible to bring someone for a local training to, if that would be arranged?
Are you looking for particularly are you looking for a particular topic on drug-endangered children, on treatment? Can you be more specific?
I'm speaking of today's webinar. I heard you say that it is available in video format, so perhaps we would be able to do that ourselves. But it's very powerful, and the discussion and training, I'm just wondering if it is available for a larger audience to present all this information.
Well, I'm sure that a lot of this information will be presented at the conference that Commander Moriarty was talking about.
And hopefully we'll send some people. I was just wondering if it might be available for, if arrangements could be made for say, a statewide or a regional conference.
What state are you in?
I'm in Wyoming. I'm actually with the Northern Arapaho Tribe on the Wind River Reservation and part of the Indian Country Meth Initiative.
Commander Moriarty, do we have a local DEC in Wyoming?
We don't have a state DEC alliance in Wyoming, but we do have several local people that are doing some of the training. If you want to get a hold of us you could just go to the National Alliance for Drug Endangered Children website, and that was on that last slide, the www.nationaldec.org. We have a training request form on there, and you can complete that and fill it out. We actually have several different, it's kind of hidden down there in the bottom, but you can see it there. We have a training request form, and then we have a training that we've put together for community awareness, and it does communities, and we could collaborate, with the local tribes, or we could kind of work with you. So if you want to either just contact us through that website and fill out that training request form and what you think your needs are, and then as Dr. Kraft mentioned, we will be covering some tribal stuff at the national conference as well with the drug endangered children in Texas. So go through both of those lines as far as our side of it. I'm not sure about Eddie, but definitely through us, and then we can get in touch with you individually.
Thank you. And along with that, a follow-up. Is there information also on the website regarding setting up a state or tribal DEC?
Yes, when you get on the website, you can actually find several links, and you can call me directly, and my contact information is on the website as well, and I can work with you on that.
Thank you. That would be wonderful. I'm also the tribal prosecutor, so I'm very excited about this. Thank you very much.
Excellent. Thank you.
Yeah, Carol, on the last slide there, which I didn't stand to, is the contact for the National Meth Center. Our next regional center is actually going to be based out of Utah, or the talks are now in the process of opening Utah up, and I believe Utah will be your regional connect to the National Center.
Wonderful. Thank you very much.
Thank you. Once again, for questions, press star 1, please. Thank you. At this time, we're showing no questions.
Okay, I'd like to ask a question. I'll start with you, Commander Moriarty. Through some national surveys and through anecdotal information, we're hearing that meth is a problem that's going away, that it really doesn't exist anymore. What would be your response to that?
I would say absolutely not. That is not a true statement. Meth is not going away. I think what's happening, Dr. Kraft, is that people might be looking at some of the meth labs that decreased, when in reality it's just some of the means of how they're manufacturing has changed, and it always takes law enforcement time to catch up with the different manufacturing techniques. But it's not going away. As a matter of fact, we actually saw an increase with the labs over the last year. And for all of us, the use, especially when I was still in the undercover drug work, the use was still extremely high because a lot of the methamphetamine was still coming in from Mexico. So I think we try hard to reduce the manufacturing, which then makes people feel like we've reduced the meth use. In reality, only about 10% was manufactured within the United States, so use continues to be high.
Mr. Gomes, do you have anything to add?
Yeah. I'd like to add in the latest UN data that came out, I think the 2009 UN methamphetamine report shows that methamphetamine users outstrip heroin and cocaine users combined. the total numbers. We're seeing worldwide a huge influx and increase in methamphetamine use. We've been seeing some alarmingly large manufacturing processes in Southeast Asia. I believe there was a lab in Sekondi, India, that had the ability to cook methamphetamine in a vessel that was able to cook a ton per vessel. In this warehouse where they're producing, there were 5 vessels for production. So 5 tons at a cook. I think we're going to see a dynamic shift in our supply lines. I don't think it's going away locally here with the economic and fiscal problems we've been having nationally and locally. Our union, our latest data from the diagnostic laboratories that do random drug testing for our unions, we've seen a 33% rise in positive methamphetamine UAs, and that was based on a 10,000 person random database. So I don't think the problem's going away at all.
How we could best access this UN Meth report, this 2009 UN Meth report you're referring to?
I will include a link to that. I'll get that to you if everybody can attach to your database, or you can go to the UN drug control website, and it is on there for everybody's viewing. The Sekondi lab was actually a joint effort between Department of Defense and the government of Indonesia. The interesting point about that is where the methamphetamine was being processed had a very large production facility, very large warehouse that they were producing in. To make crystal meth, you have to have some kind of cooling process to formulate the crystal. Most people use refrigerators. These people had forklifts and drive-in coolers. The very interesting point about this within the whole compound, there were bunk rooms, there were eating rooms, but there was also a prayer house there. And if we can try and connect the dots, I think everybody can come to the same assumption of why it was being produced and what the focus was of this lab in Sekondi.
Okay, we have another question for you, Mr. Gomes, from Kara Schmidt. She'd like to know, what is the difference between the HOPE probation program and a typical drug court?
When we look at the typical drug court, the sanctions usually aren't immediate. In the HOPE probation, that sanction is immediate. There's a concerted effort by all that are involved or connected to this program through not only the drug court, but the sheriff's office, the warrant section, that the sanction, if somebody doesn't show that warrant, goes out the same day. A lot of times with regular drug court, there's a lag and there's a talk period, and that warrant may not go out or be served for a number of times. This sanction is very immediate. One of the things they've done is connected HOPE probation to the local police department and our Crime Stoppers program. So if you fail your UA or don't show for a meeting, when that warrant is issued, the local news stations, Criminal of the Week, funny thing, you become Criminal of the Week, and your picture's up there for everyone to see also for reporting your location so you can be picked up. So people that are out there know how swift Judge Alm has been in his program sanctions. They tend to abide by it. It's been highly successful again.
Okay, do we have any more questions at this time?
We have no questions from the phone.
Okay. Well, that's going to then complete our time here today. We would like to thank all of you who have participated in today's webinar. We are excited to announce that due to the tremendous feedback from our participants, we will be adding one additional webinar to this series entitled Maximizing Resources, a review of programs, products, and services available related to methamphetamine. Details regarding the new webinar will follow shortly. This webinar will take place on Tuesday, April 13th at 2:00 p.m. Eastern Daylight Time. If you would like to be included in these communications, please email your information to Sarah Mesa at smesa@sai-dec.com. More information regarding this series and upcoming events will be available in the future at www.methpedia.org. Thank you all for participating in today's webinar.
Thank you. That does conclude today's conference. Have a great day. You may disconnect at this time.